and then go right ahead.
Okay. Hi, everyone. Welcome and thank you for being here. I just wanted to make an announcement before we get started that if you have questions, please feel free to place those in the chat. We'll have a question and answer session for about the last 15 minutes of the seminar. My name is Katie Model. I'm a scientist at Maine Health Institute for Research, studying mechanisms of osteoporosis. And I have a co-moderator today. Andy, go ahead.
Hello, my name is Andrew Fritz. I'm a faculty scientist in the Stein Lab, studying the role of RUNX1 in breast cancer.
Okay, thank you. And so it's my pleasure today to introduce the seminar speakers. We have 3 speakers today. We have Meredith Niles, who is an associate professor in the Department of Nutrition and Food Sciences at the University of Vermont. Dr. Niles is an interdisciplinary food systems scientist working at the interface of social and ecological food systems. Her primary area of focus includes farmer decision-making, sustainable food production, and food and nutritional security during crises, including the climate change and COVID-19 pandemic. Our second speaker is Dr. Bellarmino. She is an assistant professor in the Department of Nutrition and Food Sciences. Her background is in environmental studies, food policy, public health, and community nutrition, and she's lived and worked around the world. Her research explores social, economic, and environmental determinants of dietary intake and how food-related policies and programs can be leveraged to improve diet quality, human health, and food system sustainability. And our third speaker is Dr. Jennifer Laurent. She is a Holly D. and Robert E. Miller Green and Gold Professor of Nursing Research. She's Vice Chair of Nursing and Program Director for Nursing Graduate Programs. She's a board-certified family nurse practitioner with over 20 years experience in primary care with a particular focus in chronic disease management. Her area of research investigates brain and behavioral mechanisms that contribute to weight gain and obesity in youth. So thank you very much, speakers, for being here today, and you can feel free to go ahead and get started.
Yeah, great. Well, thank you so much for that introduction, Katie. It's wonderful to be here. I'm delighted we got invited back. So thank you for having us. And I'm really excited that my colleagues, Jennifer and Emily, are here with me today to also help present. Let me just get all of this organized. I'm assuming that's the right view, Sheila. Okay. Well, thank you for having us. Our project has been supported by the NNECTR for almost 2 years now, and we'll talk a little bit more about that. But our work, broadly speaking, is looking at the role of the COVID-19 pandemic on food security and health outcomes and changes over time during the pandemic. And so just to get us started, I always like to start by introducing our team because we have a big one. And sometimes I feel like you rush through acknowledgements at the end of a presentation, and we want to really acknowledge this broad team that we have. So our team is made up of people from the University of Maine that you can see here on the left. Today you've got myself, Jennifer Laurent, and then Emily Bellarmino, and our project coordinator, Rebecca Mitchell, is also on with us today, but you can see there's lots of other people and students that are involved. And then on the right is our team from the University of Maine, led by Dr. Chapman, who is an assistant professor of sustainable agriculture there. And what we're going to talk about today is first a little flashback. Hopefully it's not too traumatic for everybody, but a little flashback to March 2020 and how our work started and the formation of our team, which led to the National Food Access and COVID Research Team that we call NFACT. We'll talk about some of the early work that we did and the impact that we saw of the pandemic on food security. And then our NNECTR project really has 3 core areas of focus that we'll do a deeper dive on. I'll share a little bit about our project and its work on understanding how home food production, like gardening and hunting, links with food and nutrition security and has changed during the pandemic. And Dr. Bellarmino will talk about changes in diet quality and nutrition since the pandemic. And then Dr. Laurent will wrap us up talking about changes that we've observed in health outcomes and substance use during the pandemic. And then she'll also talk about some key takeaways in our future work. All right, so I'm starting with an image because I think it's important to sort of set the scene for remembering 2.5 years ago what we all experienced, which was, of course, just unprecedented, at least in my lifetime. So an image on the left from San Francisco, and then on the right from Los Angeles, empty highways, no one out, just total shutdown, stay at home, work orders. And of course, here in Vermont, we started to experience some of those things as well. But what we also saw at that time was an image here that may feel familiar to the Northeast. This is a Hannaford grocery store in Vermont in March of 2020. And there was certainly a run on pasta and sauce at that point. But this actually started to really occur even before we saw some of the first cases in Vermont. So going into grocery stores before the World Health declared this a pandemic, and starting to see things like toilet paper disappearing and other food staples. And so this was an early sign for our team that something was going on and that there could potentially be a huge impact on the food system and resulting food security issues. And so, of course, we had at the same time as these stay-at-home orders, a huge impact on the labor force. So this graphic is from the New York Times in March of 2020. And what you see here is the spike in unemployment claims that came at the onset of the pandemic. And that was far greater than, for example, the most recent 2007-2008 recession. We saw such a small spike there. This was truly unprecedented since sort of the Great Depression time. So we had a situation where people had to stay at home, people lost their jobs, food was flying off the shelves. And so it really created an unfortunate perfect storm for an impact on our food system and food security in a way that we haven't seen in this country in generations. And so at that same time period, our team started to form. So started working with our team within our Department of Nutrition and Food Sciences at the University of Vermont, Dr. Bellarmino, myself, Dr. Farrell Burtman, and also with colleagues at Johns Hopkins University to launch an online survey to actually study the impact of the pandemic on food systems. So we launched that survey here in Vermont in March 29th, I believe, of 2020. And within 2 weeks, we had more than 3,200 responses to a survey from Vermonters about the impact of the pandemic on their food system. And that survey was really a catalyst for a much larger collaborative effort that evolved from the University of Vermont and Johns Hopkins into a national collaboration of researchers using the same instrument and the same methods to study this issue. So that team came together through a variety of methods, other researchers that we knew were starting to work on the same topic. We also open sourced our survey. And so we started getting contacted by other researchers wanting to use the survey or replicate it, for example. And we wound up forming in the summer of 2020, NFACT, the National Food Access and COVID Research Team. And you can see here all the different states and institutions that are part of NFACT. And NFACT was among the largest groups that formed to try to study the pandemic and its impact on food security and nutrition. And we continue to have collaborations from this, most notably the one we'll talk most about today, which is our partners at the University of Maine, who've continued to do Northern New England research in particular. NFACT was formed under 3 core principles that I think are really relevant to the impact of our work, which was, first of all, that we work with stakeholders from the beginning. So even when we were designing that first survey in March of 2020, we had a stakeholder advisory group. We were vetting that survey and hearing from the state legislature, from state agencies, hunger organizations, the Vermont Food Bank, and others about the needs they had to understand what was going on. We also make our work open access to facilitate broader collaboration and access outside of the university. So we've open sourced our survey and we open source our publications. And then we've also tried to make our work as actionable as possible, especially in the beginning, by prioritizing public communication outputs over traditional academic publications. And so you see an example of those here. These are quick little policy briefs that we have written. They're all available on our website, nfactresearch.org. And we published these very quickly. The first one we published in Vermont and shared with stakeholders and policymakers was done within 3 weeks of the start of the pandemic. And so total NFACT put out 48 different policy briefs, and to date, we have 14 different peer-reviewed publications on this issue. So what is some of the early evidence that we found? Well, we have 5,600 survey responses in Vermont from 3 separate surveys in the first 6 months of the pandemic. We also had our Maine team join the NFACT group in the summer of 2020. So this is a 2.5-year collaboration. And we were among the first in the US to document the widespread impacts of the pandemic on food insecurity. So what you see in this top graphic here is just a subselection of some different NFACT sites and the overall food insecurity prevalence before and since the COVID-19 pandemic. And you can see that there's really sharp increases in changes in this population. These are all representative statewide surveys that were done in these different states. So on average, we were sort of finding a 30% or greater increase in food insecurity at the early start of the pandemic. We also were able to identify that this was having a disproportionate impact on certain kinds of people, including people of color, people without college degrees, and those with job disruptions in particular. But we also started to identify in some of this early work the potential for longer term impacts, which is really where our NNE-CTR work came in. So for example, in some of our early surveys, we documented that food insecure households, 2/3 of them said they started eating less at the beginning of the pandemic. And over half of those food insecure households told us they were eating less fruits and vegetables as compared to only 12% of food secure households that you can see here in this diagram, for example. We also were observing some really interesting changes that could be quite positive for food and nutrition security. So if any of you decided to start a victory garden at the beginning of the pandemic or started to take up canning and couldn't find canning jars, you were not alone. This was a phenomenon that sort of actually has been worldwide and been documented, that a lot of people all of a sudden started caring about where their food came from more and wanted to potentially grow it or obtain it themselves. And so we saw a huge spike in hunting and fishing licenses in Vermont, for example, a nationwide shortage on mason jars once the fall of 2020 hit. And we started to document those changes in our own early work in the summer of 2020. So we started to actually document that there was an increasing interest in home food production in Vermont. So what you can see in this graphic here is the percent of people who were doing home food production that said they did it for the first time or more in red and yellow as compared to before the pandemic. So in the summer of 2020, we found that 35% of Vermonters had engaged in home food production in the first 6 months of the pandemic, but over half of those people had done it for the first time or more. And so we started to think more about that because it could have a very positive potential impact on food security and nutrition. So all of that leads us to more of the specific detailed work we're going to go into today, which is a grant that's been funded by the Gund Institute for Environment at the University of Vermont, along with the NNE-CTR, which is to continue to assess the impact of the pandemic on food security and health, to further explore this food production, food security and health relationship. And then we're presenting findings today moving forward from 2 additional surveys that we have continued to do. So this was a statewide survey done in both Maine and Vermont in the spring of 2021, and then most recently in the spring of 2022. And so collectively, the data we'll be presenting from here on out is representing 2,000 Vermont and Maine residents. And the data is representative on race, ethnicity, and income within those 2 states. So I'm just going to present some of the more recent evidence that we have around home food production and food security from our Northern New England region. And then I'll turn it over to my colleague, Emily, to talk more about our diet and nutrition work. So briefly, what we have really seen related to food insecurity during the pandemic and maybe now this endemic period that we're in is some variable changes. So this graphic is showing food insecure percent of our respondents that classified as food insecure compared to food secure over the multiple surveys that we've done. And really what you can see here is that we have first of all, to start, I'd like to acknowledge that 23% food insecurity rate in the year before the pandemic is higher than other sources indicate. So it does suggest that this population that we have, either we're remembering food insecurity differently when they retrospectively were asked about it after the pandemic, or that it maybe was an overall greater food insecure population. But I think what's really useful to look at here are the trends. So we see a huge increase in food insecurity at the start of the pandemic. We actually see a decrease in 2021, but our most recent data from the spring of 2022 actually shows us almost back up where we were in 2020. And a lot of our analysis demonstrates that's the result of inflation. So it's not so much that people aren't back to work or that there isn't food on the shelves, but actually that food has just gotten so much more expensive. Food costs are rising higher than many other goods at this point in time. And I think it's important to note that 71% of our population of food insecure individuals are working, retired, or homemakers. So we've also started to look at the relationship of home food production and food security. And so what you can see here is the percent of people engaging in home food production by their food security status over time. And first of all, what we've observed is that overall, we're seeing a huge increase in the percent of people that are doing home food production in Vermont and Maine. In the pandemic, when I noted before, it was about 35% at the start. It jumped significantly in 2021 and still has increased a little bit in these representative samples in 2022. And you can also see that, generally speaking, with the exception of our most recent year of data, what we've also found is that food insecure households are the ones most likely to be doing these activities. And so we're also breaking this down by kinds of activities, and food insecure households in particular are more likely to be doing things like fishing, foraging, hunting, raising livestock, and poultry compared to food secure respondents. We've also noted there's been not only are people doing it for the first time, but they're also doing it more intensely than before. So nearly 60% of our respondents indicated that they'd engaged in some kind of home food production activity since March 2020, as I said, but over half of these had done it for the first time or more than before. And in particular, this is especially more common among food insecure households. So food insecure households more likely to be doing home food production at all, and also more likely to be doing it for the first time or increase their activity. But how does all of this relate to health and food security? So we found some really interesting results in this space and continuing to run a lot more analysis, but we have published some work last year that showed that home food production was positively associated with higher fruit and vegetable intake. So you can see here, this is a vegetable intake graphic from that paper. In light blue are households doing home food procurement or food production, and dark blue are ones that aren't. And we especially start to see, as you get up towards people eating 2 to 3 cups or 3 or 4 or more than 4 cups of vegetables per day, some of these significant differences. But this effect actually only was true for food secure households, not food insecure households, which we thought was really important to look into further. So some of our more recent research is looking at barriers for food insecure households. And we've also documented in another paper we published this year that home food production was associated with reduced emotional eating and stress. So households doing these activities were less likely to be stressed during the pandemic and less likely to have emotional eating. And we're kind of working through some of those mechanisms. Is that a result of increased physical activity, exposure to nature? These are areas that we're looking at further. And then most recently, this is a paper that we have in prep that I'm leading and I'm really excited about. We really wanted to understand, does it actually make a difference for food security? So all these households that started doing home food production at the start of the pandemic, did it actually make them more food secure? And the paper that we're working on right now demonstrates, yes, it did. And so for this paper, we used matching techniques, which is quite common actually in the medical field. It's kind of like thinking about home food production as a treatment effect, like a drug. And we look at whether or not the treatment effect, engagement in home food production, relates to food security outcomes, controlling for a lot of other demographics. And what we found was that among households that started home food production in 2020 that were food insecure, those that did that were much less likely to be food insecure a year later, and that was especially true for these newly food insecure households. So about 25% of newly food insecure households at the start of the pandemic became food secure that were engaging in home food production, compared to only 13.8% that weren't engaging in home food production, for example. So this is an area that we're spending a lot more time thinking about moving forward. So some key takeaways on this before I turn it over to Dr. Bellarmino. Home food production is really high in rural New England states, and we're documenting continued interest and growth. We think this is a really interesting finding and also very relevant for our very rural states, and that there could be a lot of ways to think about this for health and medical implications moving forward. We also are showing that, this newly food insecure group, people that became food insecure during the pandemic, were the ones doing it the most. And we are starting to demonstrate that home food production is associated with some important food security outcomes and even diet outcomes. So we're continuing to look at the relationship of home food production to diet and health outcomes in the future. So I'll turn it over to my colleague, Emily, to talk more about our research and work in diet quality.
Awesome. Thank you, Meredith. Yeah, so this was a really exciting opportunity for us to better understand dietary patterns and dietary intake and quality across our region, because there's actually relatively little evidence on this topic, even outside of a pandemic context. So we measured diet in two different ways. One, we selected a handful of key food groups, things like fruits and vegetables and dairy, and asked our respondents whether their intake, to think back to February 2020 and ask them whether their intake had increased, decreased, or stayed about the same over the time period, whether that was 1 or 2 years since February 2020. We also asked our respondents to complete the 26-item dietary screener questionnaire from the 2009-2010 NHANES. And that's a really valuable tool because it allowed us to use a standardized scoring procedure to estimate intake on a daily basis of some key food groups and dietary components. Meredith, could we look at the next slide? So thank you. So I know Meredith talked a little bit about some of the fruit and vegetable data already, but one of the things that we looked at that was really interesting was changes over time. So since the beginning of the pandemic with respect to food security. And we found that over a third of our food secure respondents were still eating fewer fruits and vegetables 2 years into the pandemic. This is super problematic when we think about the evidence linking fruit and vegetable intake to cardiometabolic health. And when we recognize that the US population, almost everyone is consuming less than the recommendations to begin with. And so a decrease in consumption and a continued decrease in consumption is something that's very troublesome. Linked closely to dietary changes is weight gain. So I'll talk about that here, but we found that in the first year of the pandemic, approximately 40% of our respondents indicated that they had gained weight in the past year. And in the second year of the pandemic, we still found a notable number, well over a third of our food insecure respondents indicating weight gain. And in addition to all of the cardiometabolic links between weight gain and health outcome, we found that individuals in our sample who were reporting weight gain were also significantly more likely to have some reported mental health challenges, so things like anxiety and depression. Next slide, please. Thanks. So one of the really exciting things that we've done recently, and this is for a manuscript in preparation, is to compare mean dietary intake for 5 key food categories with the Dietary Guidelines for Americans recommendations. So national recommendations are sex and age specific. They are also, they vary by activity level. So we assumed a moderate level of activity. And we found that mean intake was below recommended levels for all of the examined categories except added sugars, where our population was consuming beyond the recommendation, and that is no more than 10% of total calories per day. So the units for these are different across the different food categories, but we have for added sugar, it's teaspoon equivalents per day. For dairy, fruit, and vegetables, it's cup equivalents per day. And for whole grains, we're looking at ounce equivalents per day. Next slide. We also completed or created this compliance score where a 1 indicated essentially 100% compliance with a recommendation. And then the further score was away from 1 indicated a lower level of compliance or less compliance. And so we did this for each of our examined food groups with respect to age. And we chose age knowing that both Maine and Vermont have aging populations, and also that we know that dietary needs and dietary intake differ across age categories. So what we found was similar to the last slide. There was a lack of compliance with the recommendations, and this was particularly striking for whole grains. So if we look at all of the food groups nationally, whole grains tends to be people are in the least compliance with the recommendation. But I think it's notable that in our sample of almost 2,000 respondents, there wasn't a single person that met the recommendation for whole grains across the 2 states. We found that alignment with the recommendations differed by age, where we had older adults having better compliance with the recommendation. They were more likely to meet the recommendation for added sugars, vegetables, and whole grains. And then we didn't see any relationship between age and consumption of fruit or dairy. Next slide. Overall, we saw a trend where dietary intake was higher among our oldest population, so our older adults. And what we did here was we created a dietary composition score. So basically our own dietary quality index using the 5 food groups that I talked about. And so a score of 5 would mean compliance with all of the recommendations, which we didn't have because no one met the whole grain recommendation. And a score of 0 would mean compliance with none of the recommendations. And we saw on average people were meeting about 2.5 of the recommendations. Next slide. And we also really wanted to look at compliance with the recommendations with respect to food security status, given the focus of this grant. And so what we found here was that there was a significant association with food security status for fruits, vegetables, and added sugars. So individuals who lived in food secure households were significantly more likely to meet the recommendation for fruit, meet the recommendation for vegetables, and meet the recommendation for added sugar. We didn't see an association between meeting the recommendation and intake of for dairy or whole grains and our food security status measure. Next slide. So I think the key takeaways here, first of all, were that across our population, the diets were substantially misaligned with the recommendations, especially with respect to whole grains. That's where we saw the greatest deviation. In general, we saw that older adults in our sample had better alignment with the recommendations than younger adults. Food security was associated with meeting the recommendation for fruit, vegetable, and added sugar intake, but not for dairy or whole grains. And one of the things that we're really excited about continuing to explore in these data and future research is to try to understand more of the heterogeneity across our region. So not only thinking about things like food security status and age, but also trying to dive in on other demographic characteristics and community level characteristics, which could potentially influence diet quality. So, and I'm going to pass it over now to Jennifer to talk about some of the health outcomes.
Hi, everybody. Thanks for being here. The data that I'm going to present is really a snapshot of the 2021 survey results. It does not include the 2022 survey results. So I'll go ahead and start. If you could give me the next slide, Meredith. Thank you. So my area of interest, aside from obesity, which is also a chronic disease, is looking at the population and how their health is going to change and what we need to be prepared for as we move forward. And so what we found is some very interesting findings. We looked at four chronic diseases, and those were chosen based on the economic and the socioeconomic and individual toll that each of these takes on an individual. So we chose anxiety, depression, hypertension, and diabetes. And what we found, and I don't think that this is anything that's really surprising, is that we, as you can see, that there's very, very high levels of affective disorders, anxiety and depression. And there's also fairly decent prevalence, more so than what we see in the national statistics of diabetes in particular. And hypertension is really about what we see from a national standard. But what we also see here is the percentage of individuals that are newly diagnosed with either anxiety, depression, hypertension, or diabetes. And so what we did find, and I don't believe this is any big surprise to any of you, is that our food insecure respondents were more likely to experience depression and anxiety. Next slide, please. So I'd like to give kudos to Dr. Derek Devine. He was helpful, but he's a statistician that was very helpful in preparing the slide for me. So I don't have control over the cursor, but if you look at the y-axis, that's the odds ratio. And if you look across the x-axis, those are the health conditions that we examine. So we have anxiety, depression, type 2 diabetes, and hypertension. And then on the opposite side of the slide, so the right-hand side, we have percentage. And I'll kind of tease this apart for you. So the blue represents the odds ratio of individuals that endorsed food insecurity compared to those that endorsed food security. So we see definitely a higher odds ratio of about 1.75 in anxiety. And that is pretty much what I had mentioned in the previous slide. And then we also noticed post-pandemic, or really we're still in the period following the pandemic is probably a better way of saying that, in the orange, is that there was still a significant difference between those that were food secure and food insecure. So about 1.5 times greater odds ratio if you were food insecure than secure to have anxiety, but the odds ratio decreased somewhat, which represents the increase in overall anxiety that we're seeing. The yellow bar represents the percent change between the time of pre-pandemic to the 15 months following the pandemic. And what was interesting was that there was an overall decrease in anxiety being endorsed in those that were food insecure. And that's, I hypothesize that that's probably because they have been chronically food insecure and just have such a high level of anxiety and may be able to access additional food sources. When we look at depression, again, no big surprise that there's a significant difference, and these p-values were 0.001 as noted in individuals that were food insecure versus those that were food secure. So pre-pandemic, they were very high. The odds ratio was still significant post-pandemic and came down to 2, but still twice as likely to endorse depression. And there was really no interval change in that 15 months. I think what's most significant is when we look at type 2 diabetes. So prior to the onset of the pandemic, individuals that were food insecure still had a significant increase or a significant increased odds ratio, probably 1.75 compared to those that were food secure. However, when we look at the 15 months post the onset of the pandemic, there's a huge difference in those individuals that were endorsing a diagnosis of diabetes. Upwards around 5 times more likely to have a diagnosis of diabetes if you are food insecure versus food secure, representing about 187% change. So that was incredibly shocking and also daunting as we look forward and trying to care for these individuals. And then finally, when we look at hypertension, again, food insecure participants had about a 1.75 increase prior to the onset of the pandemic, and that came down a little bit, but still overall those levels are still pretty significant. We also noted the perceived stress scores were greater for those individuals that endorsed being chronically food insecure, meaning food insecure prior and then in the time following up to the survey. those that were newly or food insecure that endorsed just after the kind of that March 20th deadline or March 20th date, and then those who were also newly food insecure in the 4 months prior to the survey. Next slide, please. So when we looked at barriers to access to health in 20 to 21, we looked at the differences between those that were food insecure and those that were food secure. So similar to what we did with many of the other areas. And so we looked at a different reasons that may play in their barriers to access. And I mean, the take-home picture, it's pretty clear to see, is that those that were food insecure had much greater barriers to access to care, significantly in terms of having their appointments canceled, unable to find a timely appointment, and nervousness to go to see their primary or their healthcare provider. And so what we found, you see this increasing trend to concern in terms of we have a food insecure population that is unable to access care. And in the same population, we're seeing that they also have higher prevalence of chronic disease prevalence. Next slide, please. This, I think we were all very surprised about. This is just this represents the 2021 survey. So we were looking, I was really interested, I would say collectively we, was looking at how individuals were dealing with their financial resources. And so were there financial disparities or not having enough money impacting an individual's ability to actually take medication for their chronic conditions. And so what we found was that there was like up to 7 times, food insecure participants were up to 7 times more likely to skip or stop their anxiety or depression medication. But overall, when you look at further down in hypertension, diabetes, and whatnot, the rate of skipping and stopping medication is so concerning in the food insecure population. So in all, 5 times more likely to skip their medication related to diabetes and anxiety for everyone, but food insecure individuals were even more affected, specifically again for diabetes. And we'll need to explore that a little bit more in terms of why it's diabetes in particular. There was, and this is not represented here, there was a difference between, this is aggregate Vermont and Maine, but there was a slight higher level of skipping and stopping medications in Maine compared to Vermont. And there are I have some hypotheses about that. And so this just kind of shows, again, similar to the other slide, we have the hypertension, skipping and stopping, diabetes, skipping and stopping, anxiety, skipping and stopping, and depression, skipping and stopping their medications. And this is directly due to a lack of financial resources. So when you look at individuals pre-pandemic, they were definitely lower across all. So people weren't skipping and stopping their medication. And all of these changes compared to food secure and food insecure are significantly, statistically significant. However, when we look at the 15 months after the onset of the pandemic, you can see this just astronomical increase in individuals that are reporting skipping and stopping their medications, specifically in diabetes, but also when we look at depression, there's a 7,938% increase in somebody stopping their depression medication, and about a 300% increase in individuals that are reporting stopping their anxiety medication. So again, really concerning as we see this trend of dietary changes, increased incidence of chronic disease, and then to compound that, the skipping and stopping of medications related to medication. Next slide. So we also looked at substance use. It's hard not to look at substance abuse or substance use, excuse me, because there are increasing reports of substance use and misuse in the lay media, and it's also starting to come out in the scientific literature. So this is an aggregate sample of Maine and Vermont, and looking at alcohol, cannabis, street drugs, which we have teased out in our future survey, or our survey that was just deployed now. But this street drugs represents opioids, heroin, crack cocaine, methamphetamine, uppers, downers, pretty much anything that is illicit that isn't prescribed for them. And what we found is that individuals that were food insecure had higher levels, pretty much across all of them. Everybody reported some sort of increased use, but those that were food insecure reported higher levels of use of those four types of substances. And this was unadjusted. So this was just a chi-square analysis and didn't adjust for income, sex, education, etc. Next slide, please. And so this is a particular work of Dr. Bertman, who is unfortunately not able to be here today to present this slide. We teased out the LGBTQ plus respondents because we are finding that this is a uniquely vulnerable population. And so we really looked at individuals that were food insecure before and after, and then in the past 4 months. And then we also looked at chronic conditions. And what we found was overall, individuals who endorsed as LGBTQ plus had much higher levels of food insecurity overall compared to those that were not. And if you look at the anxiety and depression, it had much higher levels of anxiety and depression versus those that did not endorse as LGBTQ plus. And so that's a paper that's forthcoming, and also an area of interest as we move forward, and certainly with partnering with our community partners. Next slide, please. So key takeaways, and I think Meredith, you can go ahead and just, release them all, is that we're very concerned because food insecurity is high and it remains high, and our current 2022 data shows that we're back to being just as high, perhaps for some different reasons. And this is just kind of the perfect storm of not only a heightened chronic disease burden, morbidity and mortality, but that coupled with the fiscal challenges of trying to decide what you're going to pay for, and also having to choose whether you're going to use Medicaid or you're going to pay for medication or other things. We're probably in for this storm that's going to last in the long haul. Probably in 3 years, we might start seeing some of the repercussions of this, certainly by 5 and probably into 10 years. And so we're also seeing that these multiple shocks or impacts to the individuals who are identifying as food insecure are going to need resources that we're just not providing them now, and really looking at coupling of programs as we move forward and trying to help this particular population, but also Vermonters and Mainers as a whole. And so these health equity implications as we emerge and as we release the data really need to reprioritize in the aftermath of COVID-19, where we're learning how to live with that. So kind of reprioritizing where we're putting our public fiscal dollars. Overall, which is really concerning, is that, and I don't find this surprising, although you might find this surprising, is that diet quality overall is not very good for our Western Americans. We have reduced fruit and vegetable intake, and I suspect that will get even worse in the upcoming years just because of inflation and fiscal constraints. However, on the positive side, thank you for having this as the last bullet, food production is highly practiced in Northern New England. And really this has some very unique opportunities for food and also for solving some of our health challenges for those that are food secure, but also those who are food insecure. Next slide, please. So Meredith, I'm going to turn this back to you to talk a little bit about our ongoing and future work.
Great. Thank you so much, Jennifer. So just to wrap up, we just wanted to share a little bit about our ongoing work before we do some acknowledgements. So as I noted in the beginning, we've collected data in 2021, and we just wrapped up a 2022 survey as well. And this is now part of, we leveraged the NNECTR funding, and were recently awarded a 3-year USDA Rural Economic Development Grant. And so through that grant, we're going to be continuing to collect data. And what we're really hoping to do here, which is shown in this graphic from our grant proposal, is not just doing these surveys, and we're doing some interviews as well, but really trying to develop a food and health access scale for both of our states. So really combining those things together in unique ways to identify, especially in rural places, where we have gaps in food and healthcare access, and then thinking through with our data and some of our analysis, what might be some resilience strategies or economic development opportunities in those regions to help meet high need areas. So I'll just wrap it up by saying thank you for having us. And all of our policy briefs and our papers are on our website, nfactresearch.org. And we, of course, want to acknowledge all of the fantastic funding that we've had, including from the NNECTR, as well as many others, and really appreciate the opportunity to share our findings with this group in particular. Thank you so much.
I'd like to thank the speakers for a very insightful, interesting, and informative talk. If you have any questions, you can raise your hand or write them in the chat. I'll acknowledge Gary. You're muted.
First of all, this is incredibly informative, and obviously it's relevant on an immediate basis. I mean, and moving forward, just in terms of trying to understand what challenges that we're facing. What is, I think, probably equivalently important is what are some of the strategic interventions that we can take and to be able to go ahead and to overcome the challenges that have resulted from food insecurity. And they really fall into two categories. One is obviously there's certain investments that are required, I mean, financial investments to be able to go ahead and to make a difference in some of these areas. But if we just focus on what can we do with current financial resources that are available through education and communication, so that folks who are in a food insecure position right now can maximize their ability to be able to at least make some progress. And are there any particular communication and education approaches that you foresee are going to be able to make a difference?
Well, thank you for that, Jennifer. You know, you're in the clinical setting. Do you want to weigh in to start?
Right. I'm going to try and address, there's a lot there, so I'm going to try and start. So as we look at, you know, I think Vermont is uniquely situated in our interest in new care delivery models. And so as I've been thinking about this, and certainly in terms of preparing for writing in preparation of the manuscript, is really kind of looking at co-location of resources. And as I was listening, some of this data I actually hadn't seen either, but as we talk about looking at home for food procurement as perhaps helping significantly offset that chronic disease, or at least, you know, mitigate some of the target organ damage, is really including, so co-location of resources in terms of picking up your prescription, being able to see your primary care and mental health, drop-in clinics, whatnot, but maybe also co-locating of educational opportunities to learn about food home procurement. Like they can drop in and, hey, I'm interested in learning more about how I can do this or that to increase my ability to have healthy foods available that I can actually grow and produce and whatnot. So I think that we really need to look at really care delivery models, which is definitely money, but it's reallocation of money. More specifically, we spend a lot of money on working with individuals that are vulnerable and trying to get them the resources, but we're still sending them all over the state to get those resources. And it just, and if you're working 3 jobs and you have a family, and you're trying to make ends meet, that just clearly is not going to meet the needs of, I would say, our food insecure population. But I think also we're seeing that dwindling of the middle class now, because we're seeing that that classic middle class is what we call it, actually be more affected by the food insecurity and also chronic disease. So I hope I answered some of your question.
You get full credit.
Okay, thank you.
Can I jump in here too, Meredith, and say and this does have to do with the reallocation of resources as well, but one of the things that we found, and Meredith presented it early on, was that one of the groups that had higher levels of household food insecurity were households with children. And, we know not only that the United States has a number of supplemental nutrition assistance programs, but I think, really exciting passage in Vermont was the Universal School Meals Act, because that'll be really helpful. We know that children eat, depending on the kid, sometimes well over 50% of their calories come from school. And it can also be a source of some of the most nutritious foods that they eat in a given day. We also know from a long literature that parents in food insecure households will sacrifice their own diets before sacrificing their children's diets. And so if we can find ways to continually support some of our most vulnerable population subgroups, there's opportunities for these kind of cascading effects for food security and also nutrition security.
I think the only other thing I would add, Gary, is just, we're analyzing a lot of this home food production data right now too. And the next step on that is actually the one I'm most excited about, which is linking home food production to health outcomes to see if we actually see there's some reasons for that: physical activity, mental health improvement, time in nature, improved diets, et cetera. But, this is largely a strategy that is just wholly ignored, quite frankly, for the most part, I would say, in the literature. I mean, there's some studies that look at community gardens and the relationship of being in a community garden and nutritional outcomes. But as a whole scale strategy for rural states, I would say that we haven't really talked very much about this at a large scale. And so I do think it's really interesting, especially for our work being in among the two most rural states in the country, in Maine and Vermont, that thinking more about how we support households to grow their own food, forage their own food, hunt and fish in a way that is economical is a really important finding for our region in particular, and one that we're excited to continue to understand.
So in the chat, there are a few comments and questions going on here. One is for people who aren't reading the chat, that there are contact information for the group there, and also the website that you can reach. But one of the questions is, are the findings that you're finding consistent with other areas of the country, and what are the differences between different regions of the country, and specific things that are unique to this region? If anyone could address those.
Sure. So I can start. I'll put a link to our comparative paper in the chat here. This is the first large comprehensive paper that we published with 60 of our co-authors all across the country, across all of our 18 study sites with NFACT. And what you find there is largely very similar results, right? I mean, it's one of the things that's been so interesting about this collaboration is the opportunity for so many different researchers at the start of the pandemic to implement a similar methodology to actually collect comparable data. And those results are pretty compelling, I think. You see all the same trends, you see all the same kinds of households being affected, BIPOC respondents, households with children, households with job disruptions. So the comparative studies that we have done really do demonstrate that we are not seeing necessarily something unique in New England, which is even more terrifying if you start to think about what the impact of this would be large scale across the US and beyond. I would even say internationally, we see the same results too. As it comes to the specifics, I'll let Dr. Laurent and Dr. Bellarmino talk about some of the studies coming out about diet quality and health outcomes. But what I would say is I feel pretty confident to say that we are leading the largest study looking at the role of home food production during the pandemic on these outcomes. probably not only in the country, but I think internationally as well. So that is something unique, I think, about our work. But Jennifer, do you want to add?
Sure. I think that the studies are starting to come out. I don't think that there's anything really surprising. I think that ours is definitely unique because nobody's really looking at skipping and stopping medications as far as I have been able to find, which is, essential for chronic disease management. The papers are starting to trickle in about the prevalence of chronic health, but I haven't seen a whole lot. Now, substance abuse is a whole different matter because that's all over the media, and it's in the literature about the effect of COVID-19 on opioid use, overdose deaths, and we have a colleague that we're working with also at UVM that is working with looking at some of that as well. And we're partnering with her a little bit and kind of bridging the opioid use disorder population within our particular survey and area of interest.
Sorry, I couldn't unmute myself. With respect to diet, what we're seeing really tracks with what's been identified in national studies. What I think is really exciting about our diet data is that there really isn't representative data from our region on what people eat. NHANES is where a lot of the national diet studies come from, but NHANES doesn't disaggregate their data by geographic location for confidentiality reasons. And so it's really novel to have these population level state representative surveys to try to understand what people are eating. The other thing that I think is really exciting about our data in this respect is because we collected so many other pieces of information. As Meredith mentioned, the home food production, questions about healthcare use and changing behaviors. There's a whole breadth of information here that I think some of the analyses that we're going to be able to do will go far beyond what you could do with data that would be available to us otherwise. So it's really exciting to be able to get a really nice picture of what diets might look like in our region, even though our instruments are limited in some ways. They bring unique strengths.
Again, I'd like to thank the speakers today for a really interesting talk. I guess with that, we'll end for today. But I'd also like to mention that we have the next seminar coming on December 9th. If you would join us for that one, that would be great. Thanks so much.
Thank you.
Thank
Thanks,
you,
everyone.
Take
Thank
care,
you.
everyone.